Good evening, everyone, and welcome to today's tutorial. We'll be looking at a very interesting topic, seizure disorders and its management in the ICU. I hope you can hear me.
We can hear you, sir. Good evening, sir.
Yes, sir.
Good evening, thank you. The others will join us. Learning outcomes we'll look at the end of the day. Everybody should be able to describe common causes of seizures, particularly in the critically ill patient. Should be able to outline the immediate assessment and stabilization management. Should be able to demonstrate knowledge of first line management and second line anti-epileptic medications. And we'll talk about EEG, electroencephalogram, the monitoring, and the need to do anesthetic infusions, especially in refractory status epilepticus. All right. You should, at the end of the tutorial, be able to identify and manage refractory seizures and non-convulsive status epilepticus. All right. Hopefully, we'll talk about continuous EEG interpretation and advanced pharmacotherapy. All right. We're going to follow this outline. All right. So, by way of introduction, seizure disorders, as we know, are neurological conditions which are characterized by predisposition to generate recurrent unprovoked seizures resulting from sudden, abnormal, and excessive electrical discharges in the brain, which transiently disrupt normal neuronal function. So it's a neurological condition and it's characterized by spontaneous generation of recurrent unprovoked seizures resulting from sudden, abnormal, and excessive electrical discharges in the brain. All right, the incidence of new-onset seizures in the ICU is about 0.8 to 3.5%, all right, and it differs from one center to another. When seizures become chronic and recurrent, it is now referred to as epilepsy. All right, so a brief differentiation between seizures and epilepsy. It is good to know that seizures are often symptoms of underlying health problems. It could be symptoms of a disease process, fever, temporary medical, neurological, or neurosurgical illnesses. Often with seizures, all right, after the illness has resolved, the seizures abate, do not occur again. So that is about seizure. Why epilepsy is a chronic, ongoing series of seizures, and this can develop at any age. Often, seizures here reoccur frequently, and they are often without a known cause, unlike the one we described earlier on. All right, just a brief revision of the temporal of the lobes of the brain. All right, I just felt I needed to include this here. We have four major lobes: the frontal, parietal, temporal, and occipital lobe. And each of these lobes are responsible for specific functions. And abnormal discharges in any of these lobes will lead to very peculiar seizure disorders. So we know the frontal lobe, all right, which is located in the anterior part of the brain behind the forehead, is usually responsible for executive functions and motor control. So it's the primary motor cortex, all right? And in the left hemisphere, we have the Broca's area, which is responsible for speech. We talk about executive functions, planning, decision-making, problem-solving. All right, the frontal lobe is also responsible for personality and social behavior and helps in regulating emotions. So damage, be it trauma or electrical, sudden electrical provoke discharges in this region can lead to the three P's. I call it the three P's. It can lead to personality changes, poor judgment, and paresis, usually hemiparesis. So when they affect the bronchial area, this patient will have difficulty speaking, but note that their comprehension is usually intact. And we're going to see the difference between here and the other lobes as we go on. The parietal lobe is located behind the frontal lobe, all right, which is directly superior to the occipital lobe. Okay, it functions as the somatosensory processing center, which deals with the TPs, the touch, temperature, pain, and proprioception. So damage to this part of the lobe of the brain can cause contralateral sensory loss, or what we know as the neglect. Okay, the neglect syndrome, where the patient deliberately ignores the affected side. We have the Gerstmann syndrome, which is left parietal lesion with agraphia, acalculi, finger agnosia, and left-right disorientation. The temporal lobe, this is very important, especially when we come to the point of talking about temporal lobe epilepsy. The temporal lobe usually center for auditory, is the primary auditory cortex. All right, is involved in hearing, memory, and language, the HML. Okay, the memory is really in the hippocampus, while in the left hemisphere, there's what we call the Wernicke's area. So when you have Wernicke's aphasia, the patient is fluent, but is speaking nonsensical speech. All right, the comprehension is impaired, unlike lesion in the frontal lobe, where comprehension is intact, but the effect on the Broca's area does not allow the patient to speak fluently. But here, the patient is speaking fluently, but does not have good comprehension. More importantly, for this lobe is when we have temporal lobe epilepsy, all right, which can lead to memory loss, deja vu, or hallucination. The occipital lobe, all right, this is the primary visual cortex. All right, it's located in the posterior part of the brain. You can see it here. All right. So it's also involved in interpretation of colors, shapes, and motion. And all of this is also very relevant when we're talking about cerebrovascular accidents, strokes. So damage to this lobe can cause cortical blindness. And what we call the Aton syndrome, where there's cortical blindness, but the patient denies vision loss. The patient believes he can see, all right, but there's cortical blindness. So this is just a division of the different lobes of the brain. So let's go to the etiology. All right, so when you want to talk about etiology of seizures generally, just remember Mr. Smith. It will help you. So metabolic causes, the M there represent metabolic causes, which includes but not limited to acute metabolic disturbances like hypoglycemia, hyponatremia, electrolyte imbalances. There was a patient that had recurrent seizures in ICU some time ago. All right, a lot of people were thinking about space occupying lesion, but this patient came with severe hyponatremia, and when the hyponatremia was treated, the seizure abated, the seizure stopped. So metabolic causes are very important causes of seizures. Structural causes resulting from brain injuries, either from trauma or stroke, all right, or even cortical malformations when there's a structural abnormality. M is the mutations in genes that regulate neuronal excitability, or especially those that encode voltage-gated sodium channels and all the other channels. CNS infections like meningitis, encephalitis, parasitic infections, or very importantly, the neurocysticercosis. We have immune-mediated, all right, where, we have, for instance, the anti-MDA receptor encephalitis. Idiopathic in similar cases of cases. Then we have the traumatic brain injury, tumors, hypoxia. The H is hypoxia. All right. Hypoxic brain injury can trigger acute symptomatic seizures. All right, either following an acute event like cardiac arrest or severe respiratory failure or choking. So these are the general causes of seizures in the general population. Then, if you don't like Mr. Smith, you can use HEDI, all right, as your common causes of seizures. All right, the H there talks about hypoxia, head injury, hemorrhagic or ischemic stroke, hypoglycemia or hyperglycemia. E talks about the electrolyte derangement, uremia, especially in patients with CKD, or uremic encephalopathy, all right, abnormality of sodium, calcium, and all that. Eclampsia is a common cause of seizures, especially in childbearing age, all right? Alcohol withdrawal, drug overdose, infections, all right? Then you can also, in ICU specifically, Mr. Smith also comes to play here, all right? So there are common causes of seizures in the ICU, metabolic diseases. Always look out for it, all right? Stroke or shock. Patient with sinus infection, abscesses, trauma, toxicity. We're going to look at some of the drugs that can induce seizures. Hematological causes like DIC. All right, DIC can cause seizure, and seizure can lead to DIC also. Then we have hypoxia. So Mr. Smith always come to play when it comes to causes of seizures. All right, the International League Against Epilepsy, the ILAE, all right, has reclassified seizure, all right, into three: the focal onset seizures, the generalized onset seizures, and the unknown onset seizures. Well, let's look at these two: the focal onset seizures and the generalized onset seizures. The focal one originates within networks that are limited to only one hemisphere. And this includes focal aware seizures in which the patient remains conscious, while the focal impaired awareness seizures. Here, consciousness is impaired alongside with the seizure activities, and this affects the temporal lobe epilepsy and frontal lobe epilepsy. And that's one of the reasons why I took us through a division of the different lobes of the brain. We have the generalized onset seizures here. The abnormal electrical discharges affect both sides of the brain from the onset. And it leads to TAMAN, the tonic-clonic seizures, the absent seizures where there's brief lapses in awareness. It's typically seen among children. We have the myoclonic seizures with sudden brief muscle jerks. Then we have the atonic seizures where there's a sudden loss of muscle tone. And this one is significant because it can lead to fall and associated injuries from fall. Because at the onset of the seizure, there's sudden loss of muscle tone and the patients can actually fall, all right? And if it's in a very dangerous area like fire or whatever it is, all right, this can lead to trauma-associated injuries. Then we have the specific epilepsy syndromes. We're going to talk about the three. The temporal lobe epilepsy, remember how the temporal lobe caters for, all right, is the most common form of focal epilepsy. Actually, 6 out of 10 people with focal epilepsies have TLEs. And seizures in TLE starts or involve one or both temporal lobes in the brain. often is associated with hippocampal sclerosis and refractory seizures. We have the juvenile myoclonic epilepsy, the GME, which is characterized by myoclonic jerks, generalized tonic-clonic seizures, and sometimes absent seizures. It is the most common generalized epilepsy syndrome, and it's also known as juvenile myoclonic epilepsy of Janus. All right, it first shows up in adolescence. Then we have the Lennox-Gastaut syndrome, which is a form of a severe childhood onset epileptic encephalopathy. They have different multiple seizure types. All right, we can have the tonic-clonic, we have the non-convulsive type. In these children, intellectual development is usually delayed and often worsens over time. Behavioral problems, especially including hyperactivity, agitation, aggression, autism, are common in LGS. Okay, so this is just to remind us. All right, it's taken from instruction manual of the International League Against Epilepsy in 2017. All right, classify epilepsy into three: focal onset, generalized onset, and the unknown onset. All right, and this is just a diagram to illustrate some of the things I've talked about earlier on. All right, the catch here is that all twitches are not seizures. All right, all twitches are not seizures. Sometimes you think a patient is having a seizure, or like what people say in colloquial parlance, that the patient is seizing. All right, but you need to know there are certain characteristics that will make you make a diagnosis of seizure, especially in the ICU. Like I joke with my residents, I tell them that patients with seizures usually look cute. All right, don't mind that use of word. They look cute. All right. So see, there's clonic tonic muscle movement. All right. Sometimes they may become very subtle when prolonged seizure activity leads to exhaustion. So you see the clonic, and tonic muscle movement. They're oftentimes they're unconscious and they have urinary incontinence. That's the U. You can also see teeth clenching. That's the teeth. Or sometimes they bite their tongue. All right. Then you can actually see some subtle eye movement. And sometimes this may just be the only sign. So when you see your patient's twitching, all right, you need to be sure, is this a seizure that is going on or not? So look, is this patient cute enough for me to give them the diagnosis of seizure? See clonic-tonic muscle movement, unconscious with urinary incontinence. Is there teeth clenching or tongue biting? And sometimes this can help you also differentiate between malingering. Some patients may be malingering, thinking they're having a seizure activity. So look at them. Are they cute? All right? And that will help you. All right, there are some factors that make a diagnosis of seizure very unlikely. All right, so opistotonous posture with generalized extension of the body with arching of the back. When you say that posture, seizure is unlikely, it's not a seizure. Some of our elderly patients in ICU can have Parkinsonian tremor. All right, this a lot of times we use antipsychotics, haloperidol, and all that to treat agitation, delirium. They may actually come down with Parkinsonian tremor. So you need to be sure that this is Parkinsonian tremor and not seizure. Rigors, especially patients with infection, sepsis. All right, acute withdrawal of opioids. And a lot of times our patients are opioid-based sedation. And when we do sedation vacation, sometimes they may exhibit some abnormal movement. We need to be aware of it. Is this a seizure or this patient is suffering from acute withdrawal? Patients who are, tremoring, so to say, from anxiety. Patients who have stopped sedation and patient is still on ET tube and the patient can begin to have some tremor. All right. So these are conditions that make a diagnosis of seizure unlikely in our patient. Okay, so what are seizure triggers? Okay, let's go to the mnemonic, seizure triggers. So these are the things that trigger seizure. Seizure is what triggers seizure, all right? As there is stress, emotional stress can lower a patient's seizure threshold and they can begin to convulse. Excitement and excessive stimulation, all right, from intense activities or flickering lights. When you put on light, all of a sudden they can trigger seizure. Illness or infection, often accompanied by fever. We know of these less than 6 years old that we call febrile convulsion. Patient with zero blood sugar, all right, or low blood sugar, especially in diabetics, they can come down with seizure. Underrested, lack of sleep, okay, is a well-known seizure trigger. Rebound, especially from withdrawal or missed medications, or alcohol. Alcohol withdrawal is a very important seizure trigger. A patient who has missed these are antiepileptics. Environmental factors also, such as sunlight, heat, humidity, and excessive fluid intake, and this can result from severe hyponatremia. All right. So these are some of the triggers for seizures. All right. So seizures can either be convulsive or non convulsive. So convulsive seizures are characterized by visible motor phenomenon. Most notably, we have the rhythmic, clonic, or tonic movement of the muscles. All right, the most common example of convulsive seizure is the generalized tonic-clonic seizure, often known as the grand mal. All right, which typically includes or involves three phases. The tonic phase, where there's sudden muscle stiffening. All right, sometimes this is accompanied with vocal cry because the stiffening forces air out of the vocal cords. We have the clonic phase where there is rhythmic jerking of the lips and the face. And in between this, or immediately after the tonic-clonic activities, you can have a period of confusion or drowsiness, or sometimes the patient may fall into a deep sleep. This is what we know as the post-ictal phase. So for convulsive or grand mal seizures, we have three components, three phases: the tonic phase, the clonic phase, and the post-ictal phase. The non-convulsive is very more difficult to diagnose, all right, because they are marked by subtle or no overt motor signs, all right. Instead, they are often present with changes in consciousness, all right, behavior or cognitive function. Examples include the absence seizures, what we used to know as the peptic mass seizure. All right, this is usually characterized by brief lapse of awareness, or patient may be staring or subtle eye blinking. And how many of you have noticed you're talking to a friend and the patient just stares or looks at you blankly? All right, that person may be having absence seizure. So we know what we call the focal impaired awareness seizure, formerly known as the complex partial seizure. All right, this is associated with altered consciousness, automatisms like the nip smacking and fidgeting. All right, confusion without generalized shaking. Then we have the non-convulsive status epilepticus, where there's continuous seizure activity on your electroencephalogram without obvious convulsive movements. In this group of patients, they look confused. They may have subtle twitches or may just be unresponsive. Okay, so this is just a table to just give you the differences between convulsive and non-convulsive seizures. All right, I told you about some medications that we use in ICU, all right, that can induce seizures. I call them climate. So when you have a climate change in the ICU, seizures may result. So the common antibiotics that can all right, precipitate seizures are ciprofloxacin and your carbapenem, imipenem. So ciprofloxacin can lower the seizure threshold, especially in patients with renal impairment. Don't forget your local anesthetic, lidocaine, all right? When administered high doses or systemically, may cause seizure due to its CNS toxicity. I mentioned imipenem before, all right, which is a gabapentin, known to induce seizure, especially in patients with renal impairment, or when this drug is administered high doses. In fact, meropenem has a lower risk of inducing seizures, and that's why we prefer meropenem to imipenem. Your because of its active metabolite, the norpetidine or normeperidine, is a known neurotoxic agent and can provoke seizures, especially with prolonged use or overdose. Amphetamine, these are CNS stimulants, and they can precipitate seizure by increasing neuronal excitability, especially in overdose. Tramadol is another opioid, all right, with additional serotonin and norepinephrine reuptake inhibition. In high dosage, they can lower seizure threshold, precipitating seizure activity. Efavirenz, an antiretroviral medication, is known to cause neuropsychiatric side effects in some patients, and this neuropsychiatric effect may include seizures. So this is just a table to just tell you some of the things I'm talking about. So the one on the left is from drug intoxication, and double is drug withdrawal. All right. So withdrawal from benzodiazepine, barbiturates, ethanol, withdrawal from opioids. This can precipitate seizures in our patients. All right. So seizure has physiological responses, or this is some physiological responses. I call them status. So the patient is sweating profusely, all right, maybe associated with hypothermia. Patient is tachypnic, all right, with often aposia from airway compromise or airway collapse. Airway obstruction may ensue with prolonged fits. Patient is tachycardic and may have elevated blood pressure. Urinary incontinence and systemic organ failure may result from rhabdomyolysis, for instance, all right, from the clonic activities, movements. You can have some muscle breakdown, and DIC may also ensure. So these are some of the physiological responses to seizures. So investigations, seizure, making a diagnosis of seizure or investigating seizure disorder can be very widely varied. All right, but you want to do ABGs, all right, to look out for hypoxia, metabolic acidosis, and raised lactate. You want to rule out infection with your full blood count, your C-reactive protein. All right, serum glucose. You want to ensure that this patient is not seizing from hypoglycemia. All right, renal function test, liver function, and all that. CK, your creatinine kinase from prolonged feeds. All right, you want to rule out pregnancy in patients, women of childbearing age. Also, you want to screen for blood toxicology, all right, from blood or urine, especially for patients who may be on illicit drugs or on alcohol. All right. You want to measure anticonvulsant level. A lot of times, patients who are known the epileptic patient may have low therapeutic doses of their anticonvulsant medication. So you want to assess the serum anticonvulsant level. Chest X-ray to rule out malignancy, infection, aspiration. And you want to do some imaging, right? The CT of the brain or MRI, especially when seizures are prolonged, or there are no obvious precipitant, or if there's presence of focal neurology, papilledema or head injury, you want to do a CT brain or MRI. Lumbar puncture may be indicated, especially if you're thinking about CNS infections. Blood, urine, sputum, and all of that. More importantly, EEG is important. We're going to be looking at the EEG very briefly as advised by neurologists. Suffice to say here that managing seizures is a multidisciplinary teamwork involving your neurologist, all right, in the management as early as possible. I remember a patient that we just discharged from ICU, a young lady who had some very abnormal presentation of seizures. It had maclonic seizures like, and after we've done our first level medications, we had to involve the neurologist. And this patient was actually on polytherapy of anti-epileptic drugs. But thankfully, the seizures abated when we try to look for the cause. So it's important to involve your neurologist as early as possible. Okay, further assessment, all right, perform fingerprint blood sugar test. And if patient is hypoglycemic, you want to give 50 ml of 50%, all right? And it said that the need for hypoglycemia correction outweighs the risk of exacerbating cerebral ischemia. There are times when patients are, have ischemia or traumatic brain injury, we don't want to use glucose-containing solutions. But if the seizure is from hypoglycemia, you better correct it, all right? If the patient is alcoholic or is malnourished, it's better to give thiamine, all right, over 10 minutes. If the seizure occurs in women of childbearing age, it's very important to rule out pregnancy. And if you suspect eclampsia, all right, from other components of eclampsia, you want to follow the protocol by instituting magnesium sulfate therapy. All right, so electroencephalography. All right, so we can have different types. We have the routine, which can demonstrate epileptiform discharges. We can have the video EEG monitoring. This usually the gold standard for correlating clinical events with EEG abnormalities. Usually done when the patient is having seizure activity. All right, ambulatory EEG may be useful for patients who have infrequent events over extended periods of time. Neuroimaging it may be indicated, usually MRI, all right, for detecting structural abnormalities. Don't forget the etiology of seizures. We mentioned Mr. Smith. In emergency settings, or a CT brain will be indicated. Your PET and SPECT can help localize epileptogenic foci in patients with refractory seizures. Okay, so I just want to introduce you to this EEG, all right? There's another lecture of mine that topic neurological monitoring that I dealt with EEG, but suffice to mention it here, all right? EEG refers to the recording of the electrical activity of the brain, all right? About 20 to 22 scalp electrodes are, you can see on the right of the screen, all right, with 16 continuous traces of paper shape. All right, you look at the shape, symmetry, distribution, incidence of waves analyzed. All right, these electrical signals are then amplified and recorded as waveforms that reflect the brain's rhythmic activity. All right, so this is the first one is a normal EEG. All right, while the one under is an abnormal EEG. All right, you may be fortunate to be given this tracing in your exam. All right, and you want to be able to identify the normal and the abnormal, and you want to talk about the abnormal. So it's important for you to have a fair, idea about EEG tracing. So there are different normal waves. On the EEG, we have 4 of them: the alpha wave, the beta, the delta, and the theta waves. And each of these normal waveforms represent different activities of the patient. So when the patient is awake with the eyes closed, you have the alpha waves, all right, which is a medium frequency, high amplitude waveform, all right? The frequency is about 8 to 13 hertz, all right? When you see an alpha wave, it correlates to an awake state while the patient is still or with the eyes closed. All right, beta wave. All right, beta wave is a high frequency, low amplitude waveform. It usually depicts an awake and active state. All right, so patient is awake and active, while for alpha wave, patient is awake but is inactive with the eyes closed. Delta waves, very low frequency, all right, and high amplitude, less than 4 hertz waves, is present during adult slow wave sleep. Okay, while the theta wave, all right, is a low frequency, usually not predominant, is present during transition between awake and asleep state and during meditation. So these are normal different waveforms for the EEG. All right. So what is the role of EEG in diagnosing seizure? One, EEG can help you to detect seizure activities. When you see the high voltage elevated spike waves with, spike with slow waves. Let's say this, all right? So these are spikes, all right, EEG, and it talks about these are seizure activities going on here, all right? And for status, you have poly spikes, many spikes, but these are during normal period. Then you have some seizure activities occurring, especially around this place. Okay, so you have spike slow waves. Okay, then EEG can help you to classify the kind of seizures. All right, so the focal seizures often show localized epileptiform discharges. Whereas if it's a generalized seizures, you have synchronized spike wave complexes all over. So in between seizures, all right, you can also help you the inter-eta EEG and the eta EEG. All right, these are very useful benefits of EEG. Then for patients with drug-resistant epilepsy that you want to perform surgery, EEG will help in pre-surgical evaluation of the seizure. Want to locate the lobes and also to locate exactly where the epileptiform loci are located for surgical intervention. Okay, EEG abnormalities for patients with focal or generalized spikes. When you have spikes or sharp waves, it's suggestive of epilepsy. All right, when you have spike wave discharges, this is generalized. And we have the periodic lateralized epileptiform discharges. And we have the generalized periodic discharges. These are, all right, different EEG abnormalities. All right, the reason why I'm bringing it here is that so that when the neurologist is talking about the different EEG waveforms, you won't be looking lost. You can contribute intellectually to the discourse and the management of the patient. A patient is status epilepticus will have polyspike wave, all right, especially in convulsive time. Then we have the generalized rhythmic beta activity, all right. This is patients with non-convulsive status epilepticus, no motor component, but on EEG, you can see the generalized rhythmic delta activity, all right, and on and on. There are other common indications for EEG, especially to differentiate encephalopathy that results from metabolic or toxics and from those that originate from delirium or coma. All right, EEG is really also useful in evaluating brain death in your patient, where you show lack of electrical activity in the brain. Usually, the last investigations that can be done after you've done your bedside brainstem function test. All right, EEG helps in assessing sleep architecture. All right, in patients with sleep disorders. I mentioned this before, patients who during neurosurgical procedures, pre and during neurosurgical procedures, patients with trauma, and patients that you want to distinguish between epileptic seizures and psychogenic non-epileptic seizures. EEG will help you to differentiate that. So management of patients, general management of patients with seizure disorders, always immediately the resuscitation, you want to follow your ABC. Don't forget that they could have compromised airway due to the seizure activity, all right? Especially when there's a prolonged fit, okay? You may want to use adjuvant. And it makes sense. In those days, I don't know how many of you remember when a patient is having seizures, they try to put all sorts of things in between the patient's teeth. All right. I remember you have to put spoon. Some people put their hand. All right. Actually, those things were used as airway adjuvants, if I must say that. All right, but it's not advised. People have had their fingers, um, beaten, cut off, all right, because of the teeth clenching. And some patients have beaten their tongues with bleeding and aspiration of blood. So airway adjuvant, all right, and consider your nasopharyngeal airway instead because you could have jaw clenching and you will not be able to open the teeth. So to prevent total airway collapse, you can use your nasopharyngeal. All right, put the patient in recovery position. You want to ensure that the patient is breathing, and you want to do some cases, back mask ventilation. All right, you want to assess and monitor circulation and quickly obtain IV access. Sometimes you may require some aggressive fluid resuscitation, and you assess the conscious level as you confirm the presence of seizure. All right, pharmacology. So management strategies could either be pharmacological or non pharmacological. All right, the anti-epileptic drugs, monotherapy versus polytherapy. Evidence suggests that polytherapy is preferable. All right, especially when it's effective. Like I said, the patient we had in ICU, we had to do polytherapy. 3 different anti-epileptic drugs was what we initiated, all right, because the seizure was not abating. Their first-line agents, the sodium valproate, the levetiracetam, the carbamazepine, and oxcarbazepine, among others. And this is the choice of your antiepileptic is determined by the type of seizures, the age of the patient, comorbidities, and potential adverse effects. We're going to do some of these anti-epileptic drugs and their different likely potential adverse effects. Then we have the non-pharmacological management, surgical and neuromodulation techniques. Some, especially with the use of EEG, you may be able to localize the epileptogenic zone. All right. For instance, if it's due to mesial temporal sclerosis, all right, surgery may be indicated, may be helpful in this patient. I can't believe that up to now people still come in and leave their mic on. This is not fair. You are affecting the recording of this lecture. Then we have laser interstitial thermotherapy, or the carpal calostomy, which is used especially in patients with atonic seizures or drop attacks. We have neuromodulation techniques where you have vagus nerve stimulation, and this is beneficial in patients with refractory epilepsy where the patient is not fit for surgery. Deep brain stimulation and responsive neurostimulation are other non-pharmacological way of dealing with seizures, of managing seizures. Okay, time is fast spent, so once you see the lectures, you'll be able to read all this. These are the different anti-epileptics, phenytoin, all right, which blocks voltage-gated sodium channels and all that. Loading dose, 50 to 20 milligram IV. We're going to, let's go back. These are some of them, okay? Now let's look at this case scenario as we get into the end. All right, look at this 31-year-old female patient with a known case of epilepsy for 10 years who has been irregular, all right, on anti-epileptic drugs, usually on phenytoin, but was brought to the emergency department with recurrent generalized tonic-clonic seizures and not regaining consciousness for half an hour. All right. So the first thing is that you need to make a correct diagnosis. What is diagnosis for this patient? All right. You will see that this patient is already in status epilepticus. All right. It's a non-epileptic patient who has not been regular on medication. That is having convulsive status epilepticus. So if I'm going to ask you the diagnosis, this is a convulsive status epilepticus. So the question is, discuss your management. Like I mentioned, so we need to accurately make a diagnosis. This patient is in convulsive status epilepticus, and status epilepticus is defined as a seizure that is lasting more than 5 to 10 minutes, or a seizure that is recurrent without patient regaining consciousness in between, and it constitutes a medical emergency. And some other definition adds when the patient fails to respond to the first line treatment. Okay, so there are three different definitions in terms of duration. Seizures lasting more than 5 to 10 minutes. In terms of recurrence, patient has recurrent seizure but not regaining consciousness in between. All right, and the third one is failure of first line therapy, when the patient is not responding to the first line therapy. All right, the three major determinants of outcome in patient with SE, status epilepticus, is what kind of seizure? Is it a convulsive or not convulsive status? What is the cause? And what is the duration? How long has the patient been seizing? Okay, I mentioned this before. So we have generalized convulsive SE, which is the most common type with about 20 to 27% incidence. The non-convulsive is more difficult to diagnose, all right? And it requires, this is a kind of patient that your neurologist, or you can also order for EEG. Refractory seizures, refractory status, all right? When a seizure is lasting more than 1 to 2 hours, all right? And it's not refractory to therapy with 2 or 3 anticonvulsant agents. We can have myoclonic. What our patient had is myoclonic, all right? Myoclonic status epilepticus occurs in up to 1/3 of patients with persistent coma following out of hospital cardiac arrest. All right, it's characterized by sound-induced or spontaneous, irregular, and repetitive movements of the face and extremities. So, indications. Why will you admit this? Will you admit this patient to the ICU? All right. Why will you admit the patient when the seizure continues despite your first line treatment, recommended doses? And the emphasis is on recommended doses. You can't underdose your patient and say the patient is not responding. When the patient has unstable cardiorespiratory state, or patient has a stable neurological state, and when the patient continues to seize despite second line treatment, these are indications for ICU admission. All right, in the ICU, so patient, you are the one on call, the patient is brought to you, you are asked to admit this patient from your emergency department. So you want to, number one, you want to do airway protection. All right, you want to suction, all right, position the patient, put your nasopharyngeal airway devices, and if necessary, do not hesitate to tube this patient. You want to break seizures. The longer a seizure activity allowed to go on, the more damage to the neuronal cells. And you know, neurons do not they do not regenerate. So after breaking the seizures, you want to prevent further seizures with your second line drug like phenytoin, first phenytoin. We're going to see very briefly. And you want to do general measures to support this patient while you are ordering for investigations to ascertain the cause of the seizure and any associated complication that may have arisen. All right. So I normally tell my doctors that are working with me, when a patient is in status, I say put the patient in bags, all right, or put the patient in a bag. You're going to understand that very briefly. But before you put the patient in a bag, you want to do general principles, all right? Identify and treat the underlying causes. Fingerprint. Let's do what is the blood sugar like? Any electrolyte imbalances that we want to correct. I told you about the patient who has seizures due to severe hyponatremia. All right. Then breathing, you want to ensure that your ABC is in place. Okay. Then the first one, the B there is benzodiazepine. The first line agent is benzodiazepine. You want to break the seizure as soon as possible. So lorazepam at a dose of 0.1 milligram per kg, you can go as high as 4 milligram per dose, is the preferred agent. Why? Because it has a longer duration of action in the CNS and may be repeated once if seizures persist. The advantage of diazepam is that it can be given per rectal, especially if the IV access is not readily available, and you can give 0.2 to 0.5 milligram per kg per rectal. And diazepam works by enhancing the GABA alpha receptor activity, rapidly increasing inhibitory tone in the brain and helping to abort ongoing seizure activity. So the first line agent is benzodiazepine, and that is what the bag represents. Put the patient in a bag, benzodiazepine. Then number two is anticonvulsant. That is your second line treatment. If seizures continue, despite adequate benzodiazepine therapy, you want to proceed to the second line antiepileptic. All right, you have phenytoin. All right, loading dose at 15 milligram, 15 to 20 milligram per kg IV. And you want to maximum infusion, you don't want to exceed 50 milligram per minute to avoid hypotension and cardiac arrhythmias. Okay. Don't forget that phenytoin is a sodium channel blocker, all right? And it's alkaline, all right? It's present in alkaline, so it can cause venous irritation and cardiovascular depression. Phosphoenitoin is a phenytoin derivative, all right? And the advantage of phosphoenitoin is that it's more water soluble, so it leads to fewer infusion-related complications and has less cardiovascular depression. All right, for refractory status, you may want to give pentobarbital or phenobarbital, okay, at 20 milligram IV at the rate of 50 milligram per minute. It's cautioned that it can cause significant sedation and risk of hypotension. A lot of times requires ICU monitoring and continuous EEG monitoring. The G, if you've done all this and the patient is still refractory, all right, in refractory status or RSE, the seizures persist despite your first and second line treatment. A lot of times this patient may require general anesthesia. But know that in inducing general anesthesia, you need continuous EEG monitoring here. So propofol, midazolam, and ketamine, or your barbiturates may be used here. Propofol at a dose of 3 to 5 milligram per kg IV bolus for induction, and usually followed by infusion, which is titrated to suppress electrographic seizures. So you give the infusion as you're monitoring your EEG until you get to a point where you call the burst suppression of the spike waves on the EEG. Okay, but don't forget that it's usually as well with hypotension and prolonged infusion can give you a propofol infusion syndrome, all right, with prolonged and high doses. Midazolam, continuous IV infusion after loading dose, all right, like I said, always induced general anesthesia with these drugs with your EEG monitoring. The advantage of midazolam is that it has a rapid onset of action, easily titratable, and has a very short half-life. Surprisingly, ketamine and NMDA receptor antagonists at 3 milligram per kg bolus, then infusion at 1 milligram per kg has been used. All right. In fact, studies are ongoing where they're looking at giving as high as 10 milligram per kg bolus of ketamine in cases of ROSE, refractory status epilepticus. Contraindications, patients with severe coronary or myocardial disease or patients with cerebrovascular accident. We know ketamine. All right. So after put the patient in a bag, you want to do supportive care. All right. So endotracheal intubation and mechanical ventilation may be required. You want to support the cardiovascular system with your vigorous IV fluids. And if need be, you want to use vasopressor to ensure the MEP is at least 65 and above. Continuous EEG monitoring is crucial in guiding therapy in refractory status epilepticus. I can't mention that enough. Management of complications, temperature control, fever can worsen seizure threshold. So you have to ensure that this patient is normothermia. All right, monitor for abdomyolysis with your creatinine kinase, aspiration pneumonia, and you want to monitor glucose level and adequate nutrition. Okay, so lastly, we're going to talk about, this term anticonvulsant hypersensitivity syndrome. Is an uncommon idiosyncratic reaction to phenytoin or phenobarbital. Its incidence is 1 in 1,000 or 1 in 10,000. It is associated with triad of fever, rash, and lymphadenopathy. Elevated liver enzymes and lymphocytosis may occur in about 2/3 of cases. How do you manage? Discontinue phenytoin, all right, and control seizures with diazepam. These are the references. Thank you very much. I hope I was not too fast.